So, good morning, all. So, this was a 32-year gentleman who had a history of trauma 10 years back, and he had a history of some foreign body removed. This was the anterior segment finding where we can see there was a site of entry, and there is a site of entry in the anterior capsule also, and there is a cataractus lens. The pressure is normal. This was the fundus which was hazily seen, where we can see a yellowish colored scar in the inferotemporal area of the uh, uh, macula. Fovea, the reflex was very dull. It looked like there was a macular hole. OCT was not passing over it, but this was the OCT passing over the lesion, where we can see a hyperreflective lesion, which is in the subretinal or in the choroidal area, and there was intraretinal and subretinal fluid. B scan showed high reflective echo, which was persisting in the lower gains also. CT scan confirmed to be a foreign body in the inferotemporal area of the eye. As we can see, the ERG is also showing a negative B wave, so that is suspicious of early changes of sidrosis. So the plan of management was to do a cataract surgery and start or think of removing the intraocular foreign body also. So phaco was done, and after doing the phaco, we could see that there was a lesion in the inferotemporal, and the PVD was induced utilizing a tricot. And when we were utilizing the tricot, as you can see, the PVD was not very easy in this case. The chandelier was put because we were thinking that probably we need to use a bimanual approach. So in this case, we did a small retinectomy at that point. And once the phaco was done, the lens was not placed, but a small PC opening was done so that we have a scaffold where we can keep the intraocular foreign body once taking out. So PFCL was placed to, if at all the foreign body falls from the hand. So the problem in this case was, as we can see, that foreign body is very densely adherent, and it is probably incorporated into the choroid. So when we are trying to pull it, the whole choroid and the whole lesion itself is looking to get elevated, as we can see. So in this case, we had to utilize the MVR or a 24 gauge needle to incise the part of the capsule and then take the foreign body out. And then is when the foreign body came out, and then using a handshake technique, we took it into the anterior chamber and then took it out from the corneal or the limbal wound. So right now, that's what we are seeing, that once it is out, I'm keeping it into the in between the scaffold where the anterior capsule and the posterior capsule is there, and then handshake technique utilizing to take it out, and then aligning the foreign body in the long axis and then taking out from the phaco tunnel itself. So once this was out, and then we had placed the lens, and then the rest of the area, because this was kind of a very chalky small fragments, what we are seeing is probably the rust around the foreign body. So that was also removed, and then the inverse peel was done, and the case was closed with gas. And this was a post-op finding, as what we can see after surgery. This is 1 month where we can see a scar in the inferotemporal area and the macular hole which is closed. Visual improvement was not very significant. So thank you for my presentation, and probably we take over the next presentation also.
Yes.
Yeah,
Yes. Thank
thanks.
you, Dr. Divyansh, for